Well, hello, and welcome to Let's Talk SADS Live, Canada. I'm your host, Shu Sanitani, and delighted to be coming to you from Vancouver. So, good morning from Vancouver, and good evening, good afternoon. I understand a lot of our viewers like to tune in the comfort of their home uh, after hours and uh, in the evening. So, good evening to you, and hope you've had a great day. This is a extra session, a bonus round. We did a question and answer period last month, and the questions were so fantastic that we had to roll into a second session. So I'm absolutely delighted to be coming to you with a part two of the question and answer. It's almost like the movies now. When Mission Impossible was released, they released it as a part one so that you would be sure to tune into part two. So a little bit about us here, at the Canadian SADS Foundation, we're very proud to be continuing to support families and caregivers involved in sudden arrhythmia death syndromes, SADS conditions that have affected so many of our viewers and our supporters. Sudden arrhythmic death is, of course, a tragic event and not always preventable, but always an opportunity to save lives with appropriate referral and screening. And our job here is to provide information and collaborative learning. So that's what we're all about here at the Canadian SADS Foundation. Usually I will make some sort of plea for funds and justify this plea. We're really hoping to get together at some point in person again, which of course takes resources. So but even just running these webinars, and Evan Kruger, our wonderful tech host behind the scenes, everything costs money these days, as you know. One of the things we're very excited about that the team's been working on is a new school safety toolkit, because of course so many of our SADS patients and families have young children, school-age children, and it's a really big transition where you go from being primarily with your parents to being in a totally new environment. So check out our website to learn more about our school safety toolkit. And Pam Husband, our executive director, has been working on this in the background. So check that out. And I'm going to continue my plan for 2024. In 2023, we had some mostly Canadian historical facts about great Canadians through medical history. This year we're doing Did You Know about SADS conditions, and so we've only had a few, and you may or may not remember that CPVT, the hallmark arrhythmia that is an up and down arrhythmia, bidirectional, is also can be caused by a very old medication called digoxin or digitalis, and this allowed the scientists to figure out the mechanism of CPVT. And then, of course, last month we talked about arrhythmogenic cardiomyopathy having been around since the 18th century. And Lancisi described a case. He was the Pope's physician in this book. And so even though it feels like it's very new, it's actually been known for hundreds of years. And then today's Did You Know? So this is a rather poor photocopy of the original report by the Brugada brothers, Pedro and Josep Brugada. It's not the first report of what later came to be known as Brugada syndrome. Brugada syndrome was probably recognized almost 2 decades before this report, at least. But Brugada is characterized by this abnormal ECG. And in this report, there were actually 3 young people. And so in the original report, 3 out of the 8 patients were young children, which we now know to be very different from the typical Brugada situation. Brugada mostly affects people in their 20s and 30s, and children are rarely symptomatic. The other thing is that, of course, in the early reports, the condition seemed very dangerous with this high lethality. And now we've learned much more that actually many people can have a Brugada ECG or even a Brugada syndrome and be at low risk. So with that, did you know, I'm delighted to introduce, coming back for round 2 of our Q&A, Dr. Ciorsti MacIntyre, who is the director of the Inherited Heart Rhythm Program in Halifax. So we're covering you coast to coast today in Canada. And she was a tremendous help in answering these hard questions. So we needed her back. And so I'd like to welcome Ciorsti to the studio, and we'll get started. Hi, Dr. MacIntyre.
Hello, and thank you for having me back. It's great to be here again.
And thank you for joining. And I will apologize that I'm going to try and call you Dr. MacIntyre, as is fitting for your position there. And Dr. MacIntyre has taken, she's put the schedule on hold in Halifax to join us here. So she's in the middle of procedures. And so we thank her for that. And hopefully your patients aren't watching this in the waiting room, wondering why they're not getting looked after. So I think we better jump right in, because last time the questions were so good and so challenging that we only got through about half of them. And I really thank our audience for sending these in. We of course can't go through your own personal, we can't give you personal medical advice. Hopefully you're seeing a genetic heart rhythm specialist for your care, but we definitely are going to tackle some. So I want to jump in with Brugada syndrome, continuing on my little did you know. And so the Brugada syndrome is much more prevalent in Mediterranean and South Asian populations. It seems to have a real temperature association. So our first question is, how does hot weather impact Brugada syndrome? And particularly, they're wondering if, as a patient, they should be taking special cautions around things like saunas and hot tubs. But importantly, they also ask about fever. So there's a lot of layers here. And we're starting you off with a zinger, because I know the temperature effects of Brugada are still very incompletely understood.
No, it's true. And it's a really interesting, neat question that has practical implications for people with Brugada syndrome who are trying to live their lives, but do so as safely as possible. So thank you for the question. I think when it comes to Brugada syndrome, where people are often counseled extensively is the idea of fever prevention. So for a patient with Brugada syndrome, more than the rest of the population, it's really important that if they develop a fever, that they take measures to try to reduce that. So that can include things like taking Tylenol to try to break the fever so that the body temperature is not allowed to stay elevated. And we're lucky, outside of infection, the body's pretty good at maintaining its temperature normally, but there's no question that there's circumstances where we can kind of push the body past its usual thresholds to accomplish that. So situations that are important to avoid would be ones where a person would be more prone to becoming overheated. So you can imagine, like, not Canada in the wintertime so much, but in climates where the weather's a lot hotter and people are training or doing exercise, they would be more susceptible to overheating. But even things like saunas and hot tubs could be a consideration for that as well. So it's something that often you might not get specifically counseled on in the clinic unless the question comes up. But it's a good idea to avoid, to keep your body temperature in the normal range. Because our fear is that the Brugada syndrome is more likely to be aggravated at times of increased temperature, which can lead to having an episode related to Brugada, which can involve either a fainting spell or potentially even a cardiac arrest, which was obviously something that we want to avoid.
Yeah, and even so many layers still to the question, because you've touched on some great points. So we've had some conversations in our clinic recently. Some of the children we see, they're still under investigation, so we don't know if they are or are not going to have Brugada syndrome. And so we give them the instruction. We say, I really want to see an ECG during a fever, which is pretty impractical advice, because especially in the current era, you don't necessarily want to go to the emergency department with an untreated fever and wait for 5 hours to get an ECG. So the first priority, of course, is be safe. And if you can't get an ECG promptly, treat the fever aggressively. If you already have the diagnosis, treat the fever, of course. If you're under investigation, you have to sort of work with your team to say, is the ECG more important, or should I treat the fever?
Exactly.
Another thing I'll mention is that we don't tend to restrict physical activity in Brugada syndrome, but overheating during activity is certainly a concern. So hydration in endurance events, but also some of the reports I've read is football, for example, which is very popular. I'm talking now American football, not soccer. A lot of padding, hours of very physical, and the temperatures sometimes exceed a typical fever. So really important to make sure you're hydrating and taking measures to stay cool during your sports.
It'll be interesting too as we move forward. We've gotten so much better with wearable technology and mobile technology for ECG acquisition. So maybe someday we'll have better ability for people to be able to capture ECGs at home without having to go to the emergency department. So it'll be nice to see if technology makes our lives and your lives any easier moving forward as the technology continues to evolve.
Yeah, and Tim has helpfully put in our chat to use a Cardia. A Cardia, of course, is this mobile device developed largely, I think, from the Mayo Clinic, working with engineers and industry, and now it's a very practical, readily available tool. So, well, fantastic. So we've dipped our toe into Brugada. Let's continue with a Brugada question, because let's talk a little bit about the genetics of Brugada syndrome. I found, I've followed this for a few decades, and it's still one of the most complex conditions, I think, that we look after. It should be so straightforward because it's often in families. But tell us a bit about the genetics of Brugada syndrome as we understand them today.
So like you mentioned, it is a hot topic, and it's certainly one that we discuss a lot kind of within our genetic heart rhythm community, and the tide has really changed over time.
And the pun was definitely intended. Hot topic. We were just talking about temperature, so that was scripted.
So for Brugada syndrome, when we think about the gene that we're typically associating with Brugada, it's the SCN5A gene. And over time, there's been lots of other genes that we would call minor genes, so smaller players in the game that were proposed as potentially being involved. But what we think now is that if in a family Brugada syndrome is related to a gene abnormality, it usually involves this SCN5A gene. And when we look at the electrocardiogram in people with Brugada syndrome, one of the clues that their genetic testing is more likely to come back with this abnormality is it may also take the signals within the heart a little bit longer to get from the top chamber to the bottom chamber. So that can be one of the clues that makes me suspicious that the genetic testing is more likely to come back positive. But even with that in mind, in only about a third of cases will we expect the genetic testing to come back positive. So the majority of people who've had an electrocardiogram that shows the Brugada pattern, the majority won't have this genetic abnormality that comes up. And when I'm seeing patients in the clinic, I try to kind of set the expectations in terms of how likely or unlikely a genetic test is to come back positive. But what we've also learned is that the genetics may be more complicated than that. So for some of the conditions that we talk about in the genetic heart rhythm clinic, we're expecting a gene to be guilty for causing the syndrome in a particular family. But for Brugada syndrome in particular, sometimes there can be multiple factors within an individual, within their genetic code, that might make them more susceptible to displaying the pattern over time. And there's lots of development in the field of what we call the polygenic risk scores, where an accumulation of different little changes in your DNA can add up together to show the Brugada syndrome in some individuals. So the genetics have really kind of had a lot of discussion through the years, but that one gene seems to be the most guilty in terms of causing Brugada, even though that won't be the case in many of the patients that we see with abnormal electrocardiograms.
Yeah, no, absolutely. And so SCN5A, the sodium channel gene, is and it's capable of so many things. You've heard us talk about it in cardiomyopathy or heart muscle disease, also in long QT. And among the many fascinating things, there are families in whom some members have a Brugada phenotype and other members have a long QT phenotype with the same genetic variant. So it's not that it's the protein is not just one direction or the other, it's both. And so really complicated. And of course, to your point, you always have to set up the expectation for the family that there's a chance, a high probability, that they won't find a genetic variant. And that doesn't change that you've made a clinical diagnosis of Brugada syndrome. Exactly. And so the whole process of having good genetic counseling and informed genetic testing is so important. All right, I'm going to move to a totally different direction, because you hit such a home run last month when we talked about devices. Of course, Dr. MacIntyre, as an adult heart rhythm specialist, manages far more patients with devices than a pediatric person does. Now, this person asks, what does it mean if my device has a broken lead? And does it need to be removed? But let's just talk about this concept, this broken lead. So maybe take us back a bit about, what is a lead even, and, tell us a bit about the basics here.
So when we think about devices in the management of patients who have genetic heart rhythm conditions, we often use pacemakers or defibrillators. And depending on the situation, one may be more appropriate. Oftentimes we're dealing with defibrillators in these conditions, and they're machines made by people in factories with different components. So when we think about the different components, if you have a defibrillator, you'll feel that there's a piece of metal under the skin, and that's kind of the guts of the operation. We call that the generator, and that's a combination of the battery and the computer circuitry that kind of tells the machine what to do. And then we plug into that a wire that goes through the blood vessels down into the heart in most circumstances, with a little screw that comes out the end, the lead, and that's what transmits the signals from the heart up to the computer portion of the device to tell it what to do. And these devices, they're quite reliable. They're heavily tested, but they can still certainly have problems, as you can imagine, with any technology that you interact with in your life. Your cell phone, your car, anything can have issues that develop over time. And there's no question that the wear and tear of everyday life, especially since a lot of our patients are more active and younger, can lead to problems with some of the components. So when we think about the lead, it's basically got some metal components on the inside, and it's got a silicone or polyurethane coating on the outside. And as you go through your life and you lift things, and you lift weights, or you lift groceries, and you go about your daily life, on top of the fact that the heart's beating every moment of the day, that causes some stress points on the wires. And there's a few different ways that they can become dysfunctional over time. Sometimes the coating of insulation that helps protect the lead from wear and tear can become damaged, and other times different components within the wire can break. So when we talk about a broken lead, that can mean a lot of different things. Sometimes it still works, it's just not quite as efficient as it used to be before, and then we can keep using it for a period of time. But there's no question that sometimes the wire can break completely, in which case it can no longer do its job reliably, and then we have have to figure out what we do next. So when we're dealing with a totally broken, fractured lead, then we have some decisions to make moving forward. That one of them is whether the person with the broken lead still has a good reason to have a device put in. So that's always an opportunity to take a time out and say, listen, we thought maybe they needed a device before. Is that still true? Because sometimes it's not anymore. The knowledge about the particular topic may have changed, and a defibrillator may no longer be a mandatory or highly recommended part of the treatment package. So that's always a good opportunity first. If the decision is made that a defibrillator or pacemaker is still a good part of the management program, then we have to make some decisions on how best to accomplish that. And that can be in a number of different ways that the individual patient discusses with their physician in terms of what's best for them and their circumstance. So sometimes we'll sneak another wire in and abandon the one that's broken and just leave it there, but put a new functional wire in. Sometimes we can use special tools to try to remove the broken wire and put a new one in as well, kind of like starting from scratch. And there's different factors about the type of wire that's in, the age of the wire, the patient and their other medical problems, their age when they had the device put in, that we factor into those decisions on how best to manage that patient and their device moving forward. So it's a complicated question. It's a short question, but it's got a lot of depth to it, and they're definitely questions that we think heavily about when we're seeing patients, and there's not one size fits all strategy by any means.
Yeah, and to that point, and thank you for taking us through the technical components. As a pediatric specialist, our biggest challenge, of course, is growth. So, if you can imagine a 5-year-old getting a device, a pacemaker or even a defibrillator, by the time they're 10 or 11, they've doubled the size. So the lead is going to be under a traction and a stress. So the most common issue we have, of course, is growth. And of course, the blood vessels are small, so you don't necessarily want to have a lot of leads in these young people. In general, in SADS conditions, thankfully, you can manage most of them without a defibrillator. But for those that need those devices, lots of important conversations need to take place through that device's life. Yeah, no, fantastic. And have you had some patients where you've been able to take the device out? I know a lot of patients get quite attached to the security blanket. Others have had, they've had negative experiences and they just don't want the device anymore. Have you been able to discontinue some devices?
For sure, and there's a number of different circumstances where that can come into play. So there have been times where maybe the wire has broken or an infection happens, and we're looking at having to do something with the device anyway. That's a situation where the decision might be, in 2024, defibrillator wouldn't normally be what we would go to in this condition. So that's a situation. The other situation is some people have had devices for long periods of time, and they received them long before we kind of had our current level of understanding about some of these conditions. And the way I approach this is, when I'm starting to think, listen, maybe a defibrillator might not necessarily be part of the treatment package long term, is to start those conversations early so that we know we're monitoring these devices in the device clinic. We kind of have a countdown clock for how long is left in the battery life. So we have time to make these decisions in many circumstances. And you can really start by introducing the idea, letting a person think about it while they still have a device in place. Sometimes we can even temporarily deactivate the device so that a person experiences life without a defibrillator, but with the option to turn it back on relatively easily. And kind of through that staged, not quick fire, but staged discussion over time, I've had several patients that have decided that having an ongoing defibrillator isn't necessary. They can kind of get over the attachment. But you're right, it's really tough, especially if you think that your defibrillator is necessary and it's super important and it's been part of your life for a long time, that attachment can be a real factor that's difficult to overcome, even if the objective, the science, that type of stuff is reassuring and suggests that a defibrillator might not be necessary moving forward.
Yeah, so that's a great idea about introducing the concept that this may not be a lifelong situation is great advice. Let's change direction a little. We've gone really specific. There's some great general questions, and I'm gonna edit this one a little bit. But our audience has asked, how can I differentiate between normal heart palpitations and those related to my condition? I'm just gonna ask. Let's talk a moment about fainting. Our friend and colleague Mike Ackerman often will say vanilla faint, but tell us a bit about fainting, because fainting is obviously such a big symptom that we focus on in the SADS realm.
For sure. So fainting's a real challenge because we definitely worry about danger faints that can be associated with the genetic heart rhythm conditions, but many of us will faint in our lifetime. So over half of us will have a normal, vanilla, non-dangerous, non-scary, non-danger faint in our lifetime. I've certainly fainted before. So one of the challenges that we have is to figure out which faints we need to worry about and which faints are kind of the allowable faint, the faint that we don't necessarily need to escalate therapy in one of the genetic heart rhythm clinics. So when I think about fainting, it all really comes down to the story and the circumstances of the faint that help me figure out if I need to put my worry meter high or if I can feel more reassured and reassure the patient that what they've had is a more vanilla faint. So the sorts of things that I like to consider are how the person felt beforehand. So when I think about typical normal fainting that 50% of the population will have over the course of their lifetime, there's typically a warning of some duration that happens beforehand. So typically a person will start to feel maybe a bit unwell. They get pale like a ghost. They might get sweaty. They might feel sick to their stomach while they start to feel lightheaded. We call that a prodrome, and it's kind of the warning sign that something's about to happen if you don't do something about it. And if a person doesn't lie down or sit down, they might fall down from the fainting spell. And when we think about that normal kind of fainting, it's a reflex that gets set up in the body where your pulse might fall, your blood pressure might fall, and without enough heartbeats and with a lower blood pressure, then gravity wins and you fall to the floor and then you wake back up, still feeling kind of tired for the rest of the day. So that warning faint is actually reassuring. Even though you might feel pretty miserable, it's not dangerous. The sorts of faints that I worry more about are the ones where somebody has absolutely no warning, especially if it's happened when they're emotional, they're upset, they're surprised, or they're doing physical activity. So kind of running down a soccer field and collapsing, doing that sort of thing. So a no warning or unheralded faint, especially if it's in those circumstances, worries me much more. The other thing would be if somebody hurts themselves badly when they fall, because we're pretty good at protecting our face, for example. So we'll brace ourselves when we even have the smallest warning. But oftentimes people with dangerous fainting, they don't have that sense to brace themselves for impact. So they'll often have black eyes, broken bones, those sorts of things. And that's a much more worrisome scenario. And one of the real challenges is even if our patients have conditions that make them more susceptible to danger fainting, they have normal fainting too. So we have to really be careful in terms of those history features to make sure that we don't get overly excited by a normal vanilla faint, because that can lead to us inappropriately escalating treatment to things like defibrillators or procedures or different medications that may not be indicated. So it all comes down to first principles, and the history is really, really of fundamental importance.
Yeah, wonderful answer. And we give quite a bit of advice on making sure the kids don't skip breakfast, make sure they're drinking enough fluid, and try and avoid the vanilla faint, because exactly as you say, sometimes, we will react and we'll escalate the therapy, even if it, maybe it was a vanilla faint, but we just can't be certain. And then, of course, some people are on medication that beta blockers is a medication we use quite a bit, and that can lower your blood pressure a little bit. So again, another reason to make sure you're, well hydrated and changing positions carefully, and you don't have fainting for just low blood pressure. I'm going to take liberty of answering the original question as answered, because we've done a bit of work on this, and it says, how can I differentiate between normal heart palpitations and those related to my condition? And I'll get your take on this, but my take on it is that the brain is actually not very good at telling the difference between one type of heart symptom and another. So the brain has an awareness of something's going on, but it can't necessarily tell, well, my heart rate is 230 beats per minute right now. This is abnormal. And we published a little bit of this when we found that in young people who had a procedure to get rid of their heart racing, an ablation, a lot of them still had a lot of symptoms and a lot of awareness, because the brain was just paying attention. So I think it can be really tough, and often it's the other things that are going along with it. Are you feeling like you're going to pass out? Are you having difficulty breathing? Those kind of things. But I value your thoughts on that same question.
I think the problem with palpitations is that they're super common, and all it means is that your brain is saying, hey, my heart feels funny, essentially. And a lot of the times that can correlate to normal rhythm or non-dangerous rhythm. It doesn't always mean that something's wrong. So certainly if I see somebody with palpitations in the clinic, which happens pretty much every day, a lot of it comes down to what they're experiencing. And sometimes we can get some clues from just the description of what's going on. But a lot of the time we end up relying on some tests to try to document what the heart rhythm's actually doing when a person's feeling a funny heartbeat, so that we can say once and for all, is this normal heart beating? Is it a skipped beat from the top or the bottom, or is it a rhythm abnormality? So palpitations are extremely common, but like you say, the brain's not great at being able to tell what's real from what's not. And more often than not, when we go looking for the root cause, it ends up being a pretty reassuring situation. But it's still important to tell your doctors about in the event that it's something else. But people are really good at telling us when they're experiencing something funny. But the good news is that it's not always a problem, and it's often not related to the condition that they're being treated for in the genetic heart rhythm clinic.
Yeah, absolutely. And so many people now, they have some sort of wearable, and they get these numbers, and the numbers don't necessarily make a lot of sense. They certainly don't usually they're not usually harbingers of danger. And then let's talk about just general inheritance. The person has asked, in SADS condition, is it as simple that each child has a 50% chance of inheriting the condition, or are there more factors at play to actually end up exhibiting the disease? So great question.
It really is.
And so we're really talking a little bit about, let's shy away from Brugada syndrome, where we've just said we don't fully understand the genetics, and it's multiple genetics. But let's take long QT as an example and work with that.
So it's a great question, and it's something that we try to teach our medical students and our residents about, because it's actually a really important concept. So let's take a condition like long QT syndrome, and let's say the mom has long QT syndrome, and she's got a particular variant in her genetic code that causes long QT syndrome. So for each child, they will have a 50-50 chance of inheriting mom's variant that has the potential to cause long QT syndrome. And for each kid, it's the flip of a coin. It's 50-50. And that would tell us that there's a 50-50 chance that they'll have the genetic abnormality that causes long QT syndrome. But what's really interesting about these genetic conditions is that the expression of that can be very different in different members of the same family, even the same family. So while one person might have an electrocardiogram with long QT syndrome, that's like not subtle at all. It's extremely apparent. Their QT is really long. Another family member could have much more subtle or even difficult to see QT prolongation. So different members of the same family can express their condition differently. And as a result, there's a difference between a susceptibility to the condition overall, but the degree to which they express it. So, when the way this translates practically in the clinic is oftentimes a person will go to their doctor and they'll say, hey, my brother got diagnosed with long QT syndrome. And then that will lead to an electrocardiogram, which is very appropriate. But what we don't want to see is that after that electrocardiogram's been done, if it looks reassuring and normal, we're not done, because they may still have inherited the susceptibility if one of their siblings or a parent has the condition. So we need to take it that step further and actually look at the genetics, because, while your long QT syndrome might be subtle or it might be concealed, so we look at your electrocardiogram and we can't see it, if you're put in the wrong circumstances, you could go from being a pretty low risk person to being a higher risk person. So whether that's getting started on the wrong antibiotic or your electrolytes get quite abnormal. And that's what we don't want to have happen to our patients, is for them to be transformed unknowingly into a high risk patient because they didn't actually have the ultimate test, which would be the genetic testing in that scenario, to determine if they're at risk or not. So a really important concept, because there is a difference between what you inherit versus what you express for most of the conditions that we deal with.
Yeah, no, and that additional layer of dealing with an expert who's going to educate you, even if you have a normal ECG. I mean, important reminder for our audience. I mean, an ECG is about 10 seconds of your day, and if you think about all the different states that you experience in a day, stress, exercise, joy, unhappiness, all those things, that 10 seconds may not be representative of your entire risk profile. And then on top of that, again, as Dr. MacIntyre mentions, if someone prescribes a medication that provokes a long QT in and of itself. So I'll put a plug in for Dr. MacIntyre's recent article. I think it's available on the internet. We should put it up on our SADS website. It's a very practical guideline for healthcare providers on long QT. And that came out late last year, and I was privileged to be a part of that. Yeah, no, absolutely. Now, I've been sitting on this question for a couple of months now, because this enthusiastic person asked, how often should we be having blood tests to check flecainide levels? This is a person that is referring to the condition catecholaminergic polymorphic ventricular tachycardia, CPVT. That's probably the most common use of flecainide in our SADS clinic now. We occasionally will use it for other conditions, but mostly we see it in CPVT. So tell us a bit about flecainide and the levels.
It's a great question, and it's super interesting. So when we think about CPVT, it can make a person prone to fainting spells or even cardiac arrest, and the triggers would be emotion or exercise quite classically. And when we think about how we treat CPVT, most people will be on a beta blocker, with Nadolol being the most common one. And then it's quite common for us to have to add kind of second line therapy in the form of flecainide, which is it's called an antiarrhythmic medication. It blocks particular channels within the heart, and it works extremely well for CPVT. And, if we go back to the question, how often should we be doing flecainide levels? I'll be honest, I never check flecainide levels for my patients, and I'll tell you why. So for flecainide, it's kind of interesting. So different people can metabolize it to a different degree. So what's more important to me is whether flecainide is doing its job or not. And CPVT is kind of an interesting condition, because I treat the patient, but treating the patient really involves treating the stress test in my clinic. So I like to make sure that fleconide's doing what I've asked it to, and I accomplish that by putting people on the treadmill when they come back to clinic to make sure that those skipped beats from the bottom chamber of the heart are actually being suppressed by the medication that they're on. Because when a person's on no medication and they have CPVT, we will classically see this observation where they don't have many skip beats when they're just sitting there resting. As they start to exercise and get their heart rate to a certain threshold, we'll start to see occasional skip beats from the bottom chamber called PVCs kind of occurring by themselves. Then it might progress to every other beat as a skipped heartbeat. Then they might start coming in couplets. So we'll see two of them together, or even runs where a bunch of them will come together. And what I like to see with my treatment is that those skipped beats get suppressed. So even as they accelerate their heart rate on the treadmill, we're seeing no more than the occasional single heartbeat that skipped from the bottom chamber. So I like to put fleconide to the test by saying, okay, fleconide, are you doing your thing? Is the person on enough Nadolol, on enough fleconide, where we're seeing that reassuring response on the treadmill? So it's more of a functional test, which is much more real world than just a fleconide level, which would be what the lab would tell us was how much fleconide was measured in the blood. I want to make sure that fleconide's actually doing its job.
Yeah, and I completely agree. We don't have rapid access to the testing, but I think if the patient's response to the fleconide is not what you expect, so you're already on a reasonable dose, they may be one of these rapid metabolizers, and then I think it is reasonable, if you have access to the test, to do it. That said, you can also just, probably make the adjustment based on the treadmill test. We do rely very heavily on the treadmill test. Certainly an interesting question to ask amongst our genetic cardiology colleagues, because I suspect there's quite a range in both access to the test and responses.
Absolutely.
So we're almost at time, but let's finish on one question, just so we can give some very good general advice here. Can dietary changes or supplements have any impact on HCM, hypertrophic cardiomyopathy? And I think we'll maybe steer away from supplements, because that is just a huge range of, supplements could mean almost anything. But let's talk about a little bit about what we've learned in recent years about, diet and healthy living and lifestyle in terms of expressing the hypertrophic cardiomyopathy phenotype.
So it's definitely an important issue, and I think it's one that we need to keep making sure that we stress the importance of in the clinic. But if a person has hypertrophic cardiomyopathy, they're more prone to their heart muscle getting thick at baseline. And that can be even more pronounced, especially if they're put in circumstances where the heart's asked to do more. So trying to avoid high blood pressure so that the heart doesn't become even more stressed. And it's kind of like if you go to the gym and you pump iron, your muscles get thick. When you have high blood pressure, your heart has to squeeze against that high blood pressure, and it may get even more disproportionately thick than it otherwise would. So making sure that a person has lifestyle changes that avoid those types of stressors is really important. So if I have a patient with hypertrophic cardiomyopathy, I'm much more likely to counsel them about avoiding like extreme heavy lifting where they'd have to grunt and groan, because that can put extra swings in the blood pressure that might promote the heart muscle getting thicker. Whereas I worry much less about activities where there's no strain, they can have a normal conversation throughout it, and making sure that over time that their other risk factors don't change, so that they don't develop the typical cardiac risk factors that we would associate with artery blockages, like diabetes and high blood pressure and high cholesterol, to make sure that their overall health stays good. So there's really so much emphasis and so much importance on having good, healthy lifestyle, including diet, and including the types of activities that you do, to make sure that we don't develop other conditions that can exacerbate the genetic heart condition like hypertrophic cardiomyopathy.
Yeah, and I think our general message, certainly across Canada, I think our message is stay active, there's certainly guidance around what constitutes, recommended levels of activity. Next month later this month, we're going to talk about arrhythmogenic cardiomyopathy, where the exercise conversation is a bit more nuanced than some other conditions. But definitely we want you to stay active, because all those other lifestyle factors can accelerate things like hypertrophic cardiomyopathy. So we're at time. I've really enjoyed our conversation. You're way better at answering these questions than I am, so I'm going to send the hard questions your way. And I think we might have to make this a annual tradition where we accumulate hard questions and bring you in. Really appreciate you taking time out of your schedule, and hopefully the operating room's not too backed up as a result. But thank you very much, and we will look forward to seeing you again.
Thank you so much. It was great to be here again, and I look forward to next time.
Such great questions, and really speaks to the high level of engagement and knowledge of the SADS, the SADS patients and the SADS community in general. And that's really something that we want to keep encouraging with this webcast, to engage Canadians and make sure that we're having an active conversation, and even a proactive conversation to help people thrive with their SADS conditions. So looking forward to being back in just a couple of weeks with a special session on arrhythmogenic cardiomyopathy. And I think we're going to tackle some really important aspects of that very complex condition. But it's been wonderful fielding your questions, and keep them coming. Check out the website, those back to school toolkits, and then we'll see if we can get those long QT document on the website as well. So thanks very much, and have a great couple